Hello, and welcome to this special ACR 2022 preview podcast brought to you by the CSF. My name is Professor Philip Meese from the University of Washington School of Medicine in Seattle, as well as the Director of Rheumatology Research at Swedish Medical Center. I am joined by Professors Janet Pope from the University of Western Ontario's Schulich School of Medicine in Canada, and Atul Deodar from the Oregon Health and Science University in Portland. In this podcast, we're going to briefly highlight and discuss some of the ACR 2022 abstracts we've selected in RA, PSA, and ACSPA so that you can better plan your time at what will be a busy and exciting Congress. Janet, to you.
I would like to discuss a few highlights of looking at JAK inhibitors and beyond in rheumatoid arthritis that's going to come at ACR 2022 in Philadelphia. And I think you can look forward to many, and I'm only going to highlight a few, and we'll probably discuss with the CSF during the meeting even more. So a couple of areas I wanted to highlight was safety of JAKs, JAKs in other conditions such as PMR, switching, and also other mechanisms of action. So JAK safety, a lot has happened since oral surveillance, where registries, billing databases, admin databases have really tried to give us an answer. So this is a large abstract, number 1984, of tofacitinib and malignancies from the French registry, which is really a large administrative database. And what they were looking at was almost 40,000 patients treated with RA, of whom at least 2,800 had received tofacitinib and 36,000 plus other MOA. And in this registry, what they found was no increase in malignancies. So that's one I would like to highlight. In addition, there are many abstracts looking at other ways of using JAK inhibitors. So just to highlight one, abstract 1107 is looking at a JAK inhibitor, tofacitinib, in polymyalgia rheumatica recalcitrant patients. So I think it's something to keep your eye on. There's also a lot of abstracts on switching within registries, JACPOT, which is a registry of registries, as well as what used to be called Corona, the Corvitas database. So abstract 1590 is looking at switching from TNF to JAK, JAK to other MOA, etc., and finding that, just like what we thought before, we're really not sure what to do next, because lots of good options, but it does appear on many of the abstracts that going JAK to JAK could make sense. We just don't know about the durability of response, but the depth of response looks quite good, if not the same as going JAK to a different mechanism. So more will come, and actually I think we need RCTs to help us there. Then just two different mechanisms of action, and hopefully I'll say these names right because I don't know how to really fully pronounce them. So abstract 2008 is dosing of a CD40 ligand antibody. It's dazodalibeg. I think it's DAZODALIBEG, so who knows exactly how to say it. But it's very interesting because it's a loading dose, randomized controlled trial, different doses, and then you see what happens over time. So that's of great interest, I think, to have another mechanism. Then there's also one that is really brand new to me. Abstract 1985 is melanocortin receptor blocker. So it's type 1 and type 3 of the MC receptor, and looking at anti-inflammatory effects. It's a randomized controlled trial, and basically I think there's modest dosing improvement, where ACR 20, 60% improvement on active treatment, and placebo is 33%. So it looks like there's something going on there. So there's all sorts of other areas that I'm not going to highlight until we get into more depth, but I think it's a few teasers for you to really look at the ACR 2022 and try to plan your time. So with that, I thank you.
Thank you, Janet. And thanks for that heroic effort to pronounce the new medications that are coming along. I always have this image when we're pronouncing these medicines of Demosthenes standing over the ocean on a cliff with rocks in his mouth, trying to enunciate properly back in the Greek days. It does sound very, very interesting. And I think the whole issue of switching from one medication to another, which we find ourselves doing every day in our practices as medicines wear off in their benefit, this is very important. And so length of effect as well as depth of effect in with these switches is very important to understand. Atul?
Yeah, I would agree. The other thing that, of course, and Janet, you mentioned that the JAK inhibitors, which actually we have been using for many years now, that has the oral surveillance study, of course, has stirred the pot. And we are all kind of looking around how to use now JAKs and where to use the JAKs and how safely can we use and can we go from one JAK to the other. And as you rightly said, there are quite a few, several abstracts related to that. And I'm looking forward to learning a little bit more as we are thinking how we should, whether we should change our practice, whether we should not change our practice. What more is coming in this area about JAK safety is going to be very important at this ACR meeting.
Absolutely. And I think the bottom line is that people with low risk, and I can only talk about RA, are not going to have, in general, cardiovascular safety events, malignancy events at a high rate, no matter what drug we use. And then the other question always will be, does what was found in the oral surveillance with tofacitinib compared to TNF inhibitors really, is it generalizable to the other JAKs? Because we'll hear a lot about filgotinib as well, a JAK that's maturing in the marketplace now, as well as baricitinib and upadacitinib. And I think the final thing is, when we're not sure what to do next in rheumatoid arthritis, after secondary loss of effect of any advanced therapy, I think the most informative will be RCTs, and we're not there yet of RCTs that will tell us after a TNF, should we go to an IL-6, should we go to a JAK, should we go to something else, or conversely, after a JAK, should we go to another JAK or something else? So I await those trials. They'll probably be investigator initiated, and I don't think we'll have data for a while.
Yeah, I think you're right. There is this RA proper study that probably you are involved in, we are involved in, but that's not being presented at this meeting. But that's a pragmatic, prospective study in these situations, exactly what you're saying, Janet. What to do when patients have failed anti-TNF? Should we go to non-anti-TNF? Should we go to JAK? And if they fail JAK, then do we go to another JAK, or do we go to another non-anti-TNF? These are all pragmatic. So, I mean, this is how we practice medicine in daily practice, but then randomized control study is going to be very difficult. These are going to be pragmatic studies in daily practice. And one such study, I'm just putting a plug. I'm not the PI on this study, RA proper, but that's not going to be discussed here. But a lot to look forward to.
I'm excited about the upcoming ACR meeting, and I am highlighting psoriatic arthritis abstracts for you to pay attention to. There's an ever-expanding repertoire of medications with different mechanisms of action that are being developed for and being approved in the treatment of psoriatic arthritis. At this meeting, we're hearing 3 abstracts that are of particular interest on IL-17 inhibitors, 5 of the IL-23 inhibitor class, and 3 from the JAK family, including 2 with the TYK2 inhibitor, deucravacitinib, and 1 related to upadacitinib. The IL-17 inhibitors include 2 abstracts related to bimekizumab, unique because it is inhibiting both IL-17A and IL-17F. We'll be hearing abstract number 17, 1042, which is the long-term safety of, excuse me, I blew that. We'll be hearing abstract number 1599, which is bimekizumab in the treatment of patients who have had an inadequate response to TNF inhibitors, 16-week efficacy and safety data, as well as the bimekizumab in biologic DMARD naive patients out to 52 weeks from the phase 3 trial. This is going to show us more about the efficacy of bimekizumab and relative safety. There's also a very interesting paper on the long-term safety of ixekizumab in adult patients with psoriasis, psoriatic arthritis, and axial spondyloarthritis that Atul, my colleague here on this program, is the lead author on, which shows the relative safety of these medications over time. And then finally, a very interesting abstract on izokibep, a relatively new nano IL-17 inhibitor, and demonstrating the 16-week efficacy and safety, which shows, interestingly, some dose-related response, which I think is quite interesting to think about in terms of the mechanism of action of the drug. There are a number of abstracts on interleukin-23 inhibitors, including 2 on risankizumab. Abstract 0308 teaches about the long-term efficacy data across subgroups of patients with psoriatic arthritis from both Keepsake 1 and 2 studies. And then there is also abstract number 2145, which looks at the 100-week results from the Keepsake 1 and 2 trials. There's several abstracts related to guselkumab. For example, the 2-year data with non-responder imputation analysis in the key domains of psoriatic arthritis with guselkumab, and then the long-term efficacy regardless of which domain we're focusing on, whether it's arthritis, skin disease, enthesitis, and the spondylitic component of psoriatic arthritis. There's also a review of the Cosmos trial over time, the sustained response in patients who had previously been on TNF inhibitors treated with guselkumab. That's abstract 2139. And then we move to the JAK family, and there is one study on efficacy of upadacitinib, a predominantly JAK1 inhibitor, out through 2 years. This is abstract number 2146. And then 2 abstracts related to the new TYK2 inhibitor known as deucravacitinib. This will demonstrate both the 52-week data with this medication, as well as the long-term safety of deucravacitinib that Roy Fleischman will be presenting, abstract 2132, in which we will be noting that there is minimal change in laboratory parameters such as changes in CBC, chemistry panel, or lipids, and also very low rates of issues such as serious safety problems with infection. So all in all, I think this is going to be a wonderful smorgasbord for you to learn about a number of different mechanisms that are en route or are already here for psoriatic arthritis treatment.
Thanks, Phil. So your discussion of the abstracts, it sounds like there's an awful lot going on JAKs, TYK2, but also other mechanisms of action, including, I guess, differences in some of the IL-17 and PSA, selective or not, safety, efficacy. So I think there's a lot there to look forward to. Atul, what do you think about PSA? Do you think we have a lot on our plate there?
Yeah, I mean, apart from the various different molecules entering into the space in psoriatic arthritis, TYK2 is the latest one, even bimekizumab, which blocks IL-17A and IL-17F. The other big thing in psoriatic arthritis, and Philip mentioned that, is the renewed interest in the axial involvement in psoriatic arthritis, and the question whether is that involvement of the axial skeleton different in psoriatic arthritis compared to, say, axial spondyloarthritis. And there are some abstracts in this meeting that Philip just discussed, mostly about IL-23 inhibitor guselkumab, and that brings a very interesting point that IL-23 inhibitor, which did not work in the axial skeleton in ankylosing spondylitis, studies were done with the combined P40P19 molecule inhibitor ustekinumab, and then of course with another specific P19 molecule risankizumab, and those two studies failed in ankylosing spondylitis, but somehow guselkumab, a pure P19 IL-23 inhibitor, seems to be working, and that's a very curious thing. And there is going to be a lot of discussion regarding those abstracts. So a lot to look forward to in the psoriatic arthritis arena. Can I tell you guys about what's happening in the field of axial spondyloarthritis if you are interested to know?
Please,
Absolutely.
Atul.
Yeah, so a lot is happening there, and there are, again, so many abstracts. On day one, which is November 12th, I've chosen it according to days, so it'll be slightly easier for people to know what I'm talking about. There are two abstracts on day one, which is the November 12th, and both these abstracts are about bimekizumab, and Philip already mentioned bimekizumab is a new IL-17A plus IL-17F inhibitor. So it not only blocks IL-17AA homodimer, IL-17AF homodimer, but also IL-17FF homodimer. And this is a phase 3 study, and we can call them two different studies, or we can call them one single study. The way it was, there was a master protocol written for this bimekizumab phase 3 multi-center randomized placebo-controlled study in axial spondyloarthritis. And patients who were seen in centers, they underwent X-ray of their sacroiliac joint, which was sent to central read. If the central readers said that this is ankylosing spondylitis, bilateral grade 2 sacroiliitis, then they entered into the ankylosing spondylitis, active ankylosing spondylitis study. And that was a 24-week efficacy safety study, typical phase 3 study, multi-center randomized, etc. If the central reader said this is not ankylosing spondylitis, then they could enter into the non-radiographic axial SPA only if they had objective signs of inflammation. So then they had to have MRI scan, and they either had to have positive MRI or they had to have high CRP, or both. And if they had that, then they would enter into the active non-radiographic axial spondyloarthritis. So this was a big sort of a unified study, and patients could get into one or the other. So on day one, which is November 12th, there are two abstracts. The first abstract is abstract number 0411. This is bimekizumab improves signs and symptoms, including inflammation in patients with active ankylosing spondylitis, 24-week efficacy and safety, multi-center randomized study. And abstract number 0544, which is bimekizumab improves signs and symptoms, including inflammation in active non-radiographic axial spondyloarthritis. And as I said, these are the two offshoots of the same study. One thing which I want to just point out is that bimekizumab slightly different, well, in many ways different than the IL-17A inhibitors that we currently have, secukinumab and ixekizumab. It doesn't really have any loading dose. It is 160 milligram Q4 weeks from get-go. One of the things that people will notice that when you read the abstract that are available to everybody, that they don't really talk about, I mean, in everybody's mind, the question is this better than the existing IL-17A inhibitors that we have? And I don't think that question will be answered by these abstracts, because there is no head-to-head comparison. But I'm looking forward to these, because that will tell us how this drug works in patients who have active ankylosing spondylitis, active non-radiographic axial SPA, and in both these studies, they enrolled patients who had failed or who had inadequate response to anti-TNF drugs. And that brings to two other abstracts on the same day, one on upadacitinib, one on tofacitinib. And this ties very well into what we were discussing earlier. And this is upadacitinib, tofacitinib will generally be used after TNF inhibitor failure, even though the oral surveillance study that we have mentioned already multiple times was in rheumatoid arthritis. The black box warning says that you should use these drugs after TNF inhibitors have failed. So abstract number 04, let me get this right. Abstract number 0414 is efficacy and safety of upadacitinib in patients with ankylosing spondylitis with intolerance to or lack of efficacy to prior biologic therapy. That is the group where upadacitinib or tofacitinib will be used, I guess, even though generally patients with ankylosing spondylitis in the clinical trials are younger than rheumatoid arthritis. So it will be of great interest to see how upadacitinib specifically worked in patients with prior biologic therapy lack of efficacy. And a very similar study is abstract number 0421, efficacy and safety of tofacitinib in patients with ankylosing spondylitis by prior biologic DMARD treatment. And so this is a post-hoc analysis on their phase 3 trial where they actually had patients who had enrolled with prior failure to TNF inhibitor. And so these two are going to be very interesting and to watch. On day 2, which is November 13th, there are a couple of abstracts that I have chosen. One is, and Philip mentioned this earlier, long-term safety of ixekizumab in adult patients with psoriasis, psoriatic arthritis, and axial spondyloarthritis. So this is a long-term safety, end of the study. So the psoriasis studies went up to 5 years. Psoriatic arthritis and axial spondyloarthritis studies went up to 3 years. So this is the end of the study, safety of ixekizumab, and 5-year, 3-year long. And several interesting things that come to your mind that, well, does this drug really, I mean, year to year, do the injection site reactions go down? Year to year, does IBD go up? Year to year, does the candidiasis goes up or down or what, etc. And so I'm looking forward to this one. This is an Ignite talk, abstract number 1042. And the other interesting one is 1043, and this is about uveitis and secukinumab. Now, IL-17A inhibitors compared to TNF inhibitors, we know that they have increased risk of inflammatory bowel disease. They can precipitate that or can have new development, incidence can go up. With uveitis, generally there is uncertainty. What happens to uveitis with IL-17 inhibitors? And this abstract number 1043 is uveitis in patients with axial spondyloarthritis or psoriatic arthritis. And they were careful to separate these out because the prevalence and incidence of uveitis in axial spondyloarthritis can be as high as 40% over the lifespan, whereas in psoriatic arthritis, it can be 10%, maybe 20%, if really for a long time, it's less. So here they're looking at the placebo comparative phase and the post-hoc analysis as to compared to placebo, how does secukinumab do when it comes to incidence of uveitis? And this is on day 2, 1043 abstract number. And the last day, which is November 14th, there is a single abstract that I have chosen. This is the late breaking abstract. This is extraordinarily important. This is L15, effect of secukinumab versus adalimumab biosimilar on radiographic progression in patients with radiographic axial spondyloarthritis. And this is a holy grail of axial spondyloarthritis or ankylosing spondylitis or radiographic axial SPA, if you want to call it that. And we want to know whether IL-17 inhibitor compared to TNF inhibitor, which one is better to reduce the rate of progression? There is a lot already published about TNF inhibitors looking at retrospective analysis of various cohorts. And we know that it does reduce the rate of progression. There is not that much data about IL-17 inhibitor. And this is the first and the only study, head-to-head study of secukinumab and adalimumab biosimilar prospectively to look at the MSAS progression, the modified stroke ankylosing spondylitis spine score in patients with active radiographic axial spondyloarthritis. And the group that they chose is very, very active and very severe disease. And I'm looking forward to looking at this late-breaking abstract L15 on the last day, November 14th. So a lot to look forward to, even in axial spondyloarthritis.
Absolutely. It's becoming the belle of the ball, I think, for so many different options and ways of looking at things. So 2 comments. I think uveitis is really interesting because after a patient no longer responds to TNF inhibitor, if you're using it first, secondary loss of effect, say for axial SPA, we do get concerned when we go to a different MOA about what will happen to their uveitis. So I think that one will be really helpful. And then I think the big question on the late breaker of a head-to-head comparison with radiographic progression, very gutsy primary outcome. I guess I would ask you, irrespective of the data, do you think it's long enough, or do you think that, not that it's feasible, but that, say, a 5-year study would have been maybe more informative, because some people might drop out over time, which will then imbalance the arms, but also I think it's really tough to show radiographic progression over 2 years, even when you select a highly progressive group of patients.
Yeah, you're absolutely right. And we were aware of this problem, that is 2 year long enough. Historically, 2 years has been long enough. 2 years in general, if you look at the old data, the MSAS progression can be between 1 to 2 MSAS points. MSAS goes from 0 to 72. And so 1 to 2 years is thought to be beyond the minimal measurable acutely, what is the exact term I'm trying to think
Right,
here?
MID, the minimal,
The minimal
important difference that
Yeah.
they can detectable difference.
Minimal
Yes.
clinical important difference, MCID. So 2 years is thought to be appropriate. However, more recently, and these are old data, more recently, 2 years, people are thinking that people are not even progressing. In the old data, actually, it was 2 MSAS point. Now it has become 1 or even less than that. And we are facing exactly what you're saying. The problem that 2 years may not be sufficient. But that's the reason why, if you look at the baseline characteristics of these people, we know the risk factors, which patients progress. So specifically, males with extremely high C-reactive protein, with already several patients already had syndesmophytes. So syndesmophyte begets syndesmophyte. If you already have syndesmophyte, you are more likely to get syndesmophyte. So this was enriched data for patients who are likely to progress. The only thing they did not do was they didn't give people cigarettes to smoke, because that's one way of beyond
Very
that.
unethical
So,
if they had done it. So good thing they didn't. Yes.
Males, high CRP, existing syndesmophytes, and that's how the data was enriched. But you're right. I mean, if it was extended to beyond 2 years, we would have probably seen something different. But again, as you rightly said, then it's very difficult to extend a study for that long. Patients may not stay on that, and then the other problems occur. Then both groups become not comparable, etc., etc.
Absolutely.
And it is gutsy. I mean, that's a very appropriate adjective that you used, to be looking at this head-to-head study. I mean, that's a very gutsy on the part of the company to do that study, knowing that they may fail, but they still went ahead and do. And that's how science goes ahead. And I'm amazed that they did this. So.
Right. So I think for the listeners, a bottom line on this is that 2 highly effective agents will slow down radiographic progression. Of course, ethically, you'd never have a placebo. And maybe or maybe not, or my idea at least, of TNF inhibitors affecting both inflammation and probably osteoclasts at the level of the bone, and being perhaps the way I've thought about it, maybe even in RA, that they were always the one to beat for having the least radiographic progression. Maybe at least we can say other options, such as an IL-17 inhibitor, might indeed be equal, and we'll find out more, I think, as the meeting progresses.
Absolutely. A lot to look forward to, and thanks to you, and thanks to Philip for going over the rheumatoid arthritis and the psoriatic arthritis abstracts as well. And I've taken notes, and I'm looking forward to it.
Absolutely, myself as well. So thank you to the listeners. More to come. Bye now. So thank you, Atul and Phil. Thank you for listening to this quick preview podcast of what's to come at ACR 2022 this year in all of RA, PSA, and Axial SPA. I think we have a lot to look forward to. Make sure that you visit the CSF website at cytokinesignaling.com, where you can access the complete coverage of this year's Congress. We hope this was relevant and helpful to you, and we look forward to seeing you at the Congress, whether you're in person or virtual. Thank you.
Thank you.